Thanks once again, Hemant, Liz, Dave. It's been a brilliant week. And I have to start off with acknowledging Andrew Roberts. He's been a great mentor. He taught me a lot about gait, and this is shared work and shared data with him and the Oswestry Gait Lab. And this is just part of the information that we're extracting, which will hopefully come over the next few years. And giving this talk, some of you may remember James Richardson. And a lot of this at the gate and all my thoughts around this have been instrumental with him just opening my mind. He passed away while he was visiting India a few years ago. So anyone that comes with a potential telefemoral rotational problem, ever since day one as a consultant, they get full history, full clinical examination. I get AP long leg views. I only do adults, so the radiation is, you've got to be careful of, but they're adults. MRI of the affected knee to look for any internal derangement, and a CT rotational profile, which includes a scanogram for leg lengths, and a CT-based TTTG, because Alex Arvold and co showed that an MRI underestimates the TTTG. If the rotational profile was out of range, that's if out of range, we deal with any internal derangement in the knee because that can affect gait studies. And then I'd send them for formal gait studies in Oswestry, which is quite a trek from Southampton. But I'd explain why. In Southampton, I'd ask the question. So for this one is, does this patient need derotational surgery, or can I just do a smaller procedure, which is a tibiotubercle osteotomy, medialization, maybe distalization, whatever. So that's when to say did a distalization, they put elevation. And then they will retake the history. And you can see the number of people present at the gait assessment. There's a physiotherapist, senior physiotherapist, orthotist, clinical scientist. And that gave me also, because I was by myself in Southampton with a new service, with all these complex patients, it gave me a good access to an MDT to potentially be doing quite significant surgery. And so that's how this developed. They would do a full physiological assessment. And I'll show you some there. And that includes a list of all the impairments. So you can see coronal plane, leg length impairment, sagittal plane, carries on, how much the defects were on clinical examination, transverse plane, and importantly, expert people who are doing this for all conditions, because the Oswestry Gait Lab, a lot of it's CP patients doing muscular disorders. They're very, very good at clinical assessment. So I'd get back a full clinical assessment, and because I knew they'd read my letter, it makes me do a better clinical assessment before I send them on, because I don't want to embarrass myself. So it gives a check. Now, then you get the gait study reports, and you say, well, you could get that closer, and yes, maybe we can. They'll make comments, and sometimes they'll say, okay, we think that this person needs an EMG, and they'll do the EMG. Or because there's an orthotics workshop there, if they've got orthotics, whatever, they'll tune it up and do whatever they need to do. But what's different to gait labs around me is this combined surgical opinion from surgeons, okay? So then I'll let you read that. This is, we've got hundreds of these, so I just picked some that would be a couple. So, you know, again, they will counsel the patient, sciatic nerve monitoring. Helps a lot with me and the patient in clinic. And then they'll also say, it's not an easy option to recommend with certainty any surgery. So it gives me a powerful way of saying, listen, I can't treat you with a knife. But when, and again, this says, would gain any benefit whatsoever from derotational surgery. It'd be clear, they don't sit on the fence. And that's really helpful for you as a surgeon. But also they'll say, if something else comes up, so this was a anterior horn viral infection, and it proved to be the case. And this is one of the nurses in our hospital. They recommended surgery. And in the beginning, to be honest, I found an excuse to try and get gait studies to see whether what I did actually help. So here's someone who had we had this earlier today as well. So I did one side, which they recommended. She had the surgery. She went for the other side, before doing the other side, and said, you don't need to do the other side. So after now collecting 12 years of these patients, we decided to do data analysis. So this is some of the preliminary things with some of the preliminary data. So here's a distribution. So this is female and male, and as you'd expect, it's mainly young females. The measures, CT anteversion, CT tibial torsion, TTTG, kinematics and kinetics, exactly as we've said. I think I just want to get over the limitations straight away. We've talked about accuracy of CT measures, and I think we're all in this room pretty anxious about that. Now, none of these gait studies or reports have considered supratuberosity derotation because for PFJ type pain, you could align the trochlear with supratuberosity derotation, as you mentioned this morning, Matt, as well. And the forces that you measure don't include the joint contact force. So they can't say, well, you need a hip replacement if you've got an arthritic hip, because the gait studies don't tell you that. So this is just to get used to this color scheme as such. So this is the degree of anteversion and whether rotation was recommended. And you can see there's no correlation. So you'd expect the more the anteversion, the more the recommendation, if you went with CT rotational basis, that they'd be recommending more, but it wasn't. So that's the right, that's the left. Again, there's no pattern to the amount of anteversion and the need from gait studies identified for a derotation. Tibial torsion, again, no pattern with a particular amount of tibial torsion and gait study recommendation for surgery. So that's the left and that's the right. Okay. Coming on to symmetry of anteversion. So generally, if you had one hip that had anteversion, generally the other one would have it as well, so it's quite symmetrical. The tibia, however, isn't quite the same pattern. So this is another thing. Is there another etiology behind tibial torsion which is different to femoral torsion? And that's something that we can look at. Now, this is an unbalanced right lower limb. So this is hip retroversion, anteversion, and this is tibia. Now, what we've done is not 0 degrees of anteversion. It's 0 would be 10 degrees for a male and 15 for a female. So that's 0. So 10 would be 20 for a male and 25 for a female. So you'd expect this to be the highest tibial torsion and the highest anteversion. I'm sorry, these colors, these dots that I think I need to make bigger. But rotation needed, yes or no? The rotation needed actually feels no pattern. It's spread all over. So it's not up here and it's not down here. It's spread. So they're more around the periphery. So there might be something else going on, but it's not about a particular degree of anteversion matched with a particular degree of external torsion. So that's the right side. The left side is exactly the same, that there's no pattern from a CT-based measurement of version, even when you combine excessive hip and excessive tibia. Now, if we look at all limbs, so this is now no surgery. Yes, operate on them. So like do a tibal tubercle. Operation would mean something else apart from rotation as well. So it could be a rotation plus tibal tubercle surgery. Yes, rotation only, so you don't need to do anything else but rotate them, but this is not supratubercle. So that's why I excluded that. And yes, you've got to rotate them and do something else. And again, there's absolutely no correlation of these dots with the amount that the CT is telling us of the version of how much from population norms there is. So we thought that this is now beginning to completely change our practice. And only 10% of people that I've sent up to Oswestry, so that's all people with everything that I said and an abnormal CT rotational profile, only 10% have had surgery recommended. That means if I was just going on CT values, I've saved, from a health economics point of view, 90% of people having surgery. Also, the morbidity to the patient as well. So currently, we are sending out TEGNA scores. Now, the other thing is because we've got such well-documented, consistent clinical examination, and we do need help going through all this data if anyone is up for helping us. But correlating the CT-based findings to the clinical findings. And there's perfect set of them. There's no missing data of the clinical findings or the CT findings. And then what we need is, and that's one of the reasons to present it in this forum, because you've all got good insight, is to find out what statistical analysis we can do for this big data to see whether there's an easier way to see who should be offered derotation, who don't need derotation, and who then, because formal gait analysis isn't available to everyone. And gait analysis picks up, formal gait analysis, they picked up a load of things. Maybe there's only a bit of the gait analysis that we need. That can be, and they are smaller systems you can have in a clinic. So that's the current way forward. So in a summary, in terms of take-home message so far, that you've got to, which is exactly what we've said all the way along, I think, this week, that you've got to have a history, you've got to have clinical examination, and that the CT rotational profile may give you some other data, but it's not the basis to say, yes, you need gait studies or not gait studies. And then we've talked about saving morbidity, and it also helps pick the winners. The other thing is the patients have such an amazing time in Oswestry being looked after, 4 hours of gait analysis, that when they say you don't need surgery, normally, I'm sure as with all of you, we're the last line. They've been round the blocks over the years, and okay, you go to this in a major center, you'll see this team, and they'll sort you out. But when they go have all this and they say, well, we haven't got anything for you, you need whatever, strengthening, whatever, then they take that. Their search is over and they get on with the rest of their life. And then they engage more in the non-operative measures because it feels like they feel listened to, because I listen to them, but they get really listened to, and they get to in Oswestry as well. And then it gives me medical legal support in my decision making if anything goes wrong. And I needed surgery, there are further works. Now, the question preemptively in the last couple of minutes is how do orthopedists decide to recommend surgery? So basically, they're looking at the decoupling of the knee extension, ankle dorsiflexion couple. And then as you mentioned about the foot, that's exactly as a lever. And then if the hip's on an extreme range, then that could cause problems. But one of the other things that we have found is that sometimes the CT identifies a CAM lesion or something else, and we warn the patient that if we derotate you, that now may become a problem. So you might get a problem in your hip that's different to the problem that you've got now. So that was that. Thank you very much.